Although hypoxemia is the hallmark of acute respiratory distress syndrome, there are other challenges to ventilating patients with ARDS. The fluid-filled alveoli make the lungs of ARDS patients less compliant and at higher risk of barotrauma. Additionally, atelectasis, or overstretching of alveoli, can lead to further inflammation of lung tissues. High levels of oxygen can lead to oxygen toxicity, generation of free radicals, and cellular damage. Additionally, as ventilator settings are adjusted to improve oxygenation, hypercarbia may occur, which can lead to acidosis and cardiovascular compromise. All of these potential complications must be weighed and mitigated during mechanical ventilation of patients with ARDS. The first goal of ventilating patients with ARDS is using lower tidal volumes. In 2000, the ARDS network trial compared lower tidal volumes at 6 milliliters per kilogram ideal body weight to traditional tidal volumes, which were historically 12 milliliters per kilogram ideal body weight, and found that mortality improved with lower tidal volumes. They also found that ventilator-free days were higher. Lower tidal volumes are now universally applied to most mechanically ventilated patients and range from 4 to 8 milliliters per kilogram of predicted body weight. This is called lung protective ventilation. Another key parameter goal during ARDS network trial was keeping the plateau pressure less than 30 centimeters of water. Plateau pressure is usually less than peak inspiratory pressure and is usually more difficult to measure if the patient is breathing spontaneously. Plateau pressure is measured using an inspiratory hold feature on the mechanical ventilator. Keeping alveolar pressures low is thought to decrease barotrauma and further lung injury. As tidal volumes are decreased in lung protective ventilation and respiratory rates are limited by breath stacking, carbon dioxide levels inevitably rise. This hypercapnia leads to respiratory acidosis with lower pH values. Although the exact pH values at which complications occur is not known, most clinicians try to keep the pH between 7.25 and 7.5 to avoid the complications of acidosis or alkalosis. The goal of adding PEEP in ARDS is alveolar recruitment and prevention of atelectasis for improved oxygenation. Adding PEEP can allow for decreased levels of supplemental oxygen and therefore decrease the risk of oxygen toxicity. Oxygen toxicity is thought to occur at levels of FiO2 greater than 55 to 60% for more than a few hours. PEEP and FiO2 are titrated to a goal PaO2 of 55 to 80 millimeters of mercury or greater than 88% SpO2. In ARDS, the alveoli and interstitium become fluid-filled due to inflammation and vascular permeability. This fluid contributes to hypoxemia by limiting diffusion of oxygen across the alveoli and into the capillaries. There is some evidence that conservative fluid strategies can decrease the number of days of mechanical ventilation. As long as hemodynamics are stable and perfusion is adequate, most clinicians advocate for conservative fluid strategies in ARDS. Severe ARDS is defined by a PaO2 to FiO2 ratio less than 100. Patients who are worsening despite optimal treatment or have a P to F ratio less than 150 should be considered for adjunctive therapies to improve oxygenation. Therapies to consider include extending the inspiratory time in relation to the expiratory time, prone positioning, and neuromuscular blockers. Patients in high-resourced facilities may be considered for extracorporeal membrane oxygenation, or ECMO.